So thank you, Aspen. Today we're going to talk about COVID-19 and the brain. Very interesting. There's not a whole lot of clarity yet, but there's a lot of questions. So as you know, we've covered plenty of topics in the past, ranging from supplements, lifestyle, risk factors, new mutations, mutation rates, statin therapy, you name it. In fact, if you're like me, and like a lot of us, we're pretty sick of COVID right now. But whether we're sick of it or not, it's a major determinant of our health. And it does profit us, if we want to stay healthy and alive, to be aware of the major issues. So that's why we're continuing to cover it. We're going back into a lot of the standard coverage that we have. COVID-19, as you may have noticed, has the same major risk factors as heart attack, stroke, the major killer, the major disabler in our world. So, and what is that risk factor? Most often it's unrecognized prediabetes. So again, the issues that we've covered during the first parts of the pandemic are very consistent with the rest of our channel. It's helping baby boomers stay alive and healthy. But as you've noticed, we've been announcing this over the past couple of weeks. We're slowing down on the daily pandemic issues. They've become over-politicized. And we're going back to our once-a-week YouTube live stream schedule. And that'll be Wednesdays at 11 o'clock Eastern Time. Just a quick run through on things that matter. Your doc, there's a over 60% chance that your primary care doc does not know that much about prediabetes, how to discover it, how to warn you about it, what to do about it. You don't have to change your doc to get that gap filled in. There are ways that we can help you in that space. And the webinar is set up specifically to do that. We're continuing to have discussions about an upcoming book. And it's not so much about prediabetes. It's about another major problem that we have in this country and elsewhere. And that is, many of us know that plaque is very much associated with heart attack and stroke. Most of us assume that a stress test is a great way to find out if we're at risk. That's what Tim Russert thought. He had a negative stress test in the office of his doctor, Dr. Michael Newman, in the Georgetown district of Washington, D.C. When was it? Was it 2010? Quite a few years ago. Got a great score, passing colors, went back to his office and died from a heart attack. And when you go over this story, most people say, oh yeah, I know such and so who had the same thing. The bottom line is Google it. Google false positive, false negative stress tests. And you'll see the snippet come up, and it says, what, about 1.5 million of stress tests, negative stress tests are false negative, false positive. So when you think about getting one of those, you got to ask yourself, are you feeling lucky? Now, that's the downside. There's also an upside. There are better ways of finding out if you have risk for heart attack and stroke, and that's what the book is about. We've also got some supplements, webinars that Michelle's working on, subscription plans to help those of you who know that Medicare or your doc are not quite up to speed on prevention and would like to look at a more affordable way to get access on a regular basis to prevention programs. So as soon as Aspen gives us the water ball and the go ahead, we'll get started on COVID-19 and brains. So I don't think there are many people left that think COVID-19 just impacts the lungs. Doctors are now racing to understand one of the most disturbing targets, and that's the brain. Patients with severe cases of COVID-19 are left confused, sometimes delirious, in other words, out of touch with reality, or exhibiting signs of an altered mental state. In one case, doctors thought it was meningitis, as there were no respiratory symptoms, just the brain infection. But not until the patient was positive for COVID-19 did they realize this is COVID-19. This is coronavirus infecting the brain. The data is sparse, but here are a few studies and a few observations. In Wuhan, China, a third of the patients experienced some sort of neurological or brain and nerve-related symptoms. That rate increased among those with COVID-19, the more severe infections. A smaller study from France found that among hospitalized patients, about 2/3 were agitated or even delirious. Elderly patients are most likely to become delirious during hospital admissions. Doctors, though, are noticing that some younger patients are also exhibiting signs of altered awareness as their only symptom. Altered awareness. It's also possible that long periods of hospitalization could be making the problem worse for some patients, causing them to feel disoriented. The delirium has now confused doctors who still don't understand whether it's a result of the virus directly damaging the brain tissue or the blood vessels to the brain, or maybe a result of severe respiratory distress due, or the low oxygen levels that we've talked about with SARS-CoV-2. A side effect triggered by an aggressive inflammatory response. We've talked about that cytokine storm. Which of these could be causing this confusion and even delirium? We don't know yet. With doctors learning more about COVID-19 every day, a growing number are now on the lookout for delirium as a possible symptom. Caught early, delirium can be managed, which can in turn reduce the risk of long-term adverse effects. Aspen, are you able to show that video?
Minutes now before 9 o'clock, many people battling COVID-19 have ended up in the intensive care unit. Though they may have recovered from the coronavirus, there's a new concern now: delirium, which is a sudden and serious change in brain function that results in confusion. And joining me now this morning is Dr. Babar Khan. He is a Regan Street Institute research scientist, also a pulmonary specialist and a critical care physician. Doctor, thanks for being here to tell us about this. How are you doing this morning?
I'm doing good. Thank you for having me here.
Oh, we're glad to have you chatting about this. So first of all, this is a different wrinkle than what we have really talked about. What is the concern that you have about this delirium, and is this something that you're seeing with growing occurrences?
Delirium is a condition of acute brain dysfunction characterized by confusion, which happens when you're admitted to the hospital. It can happen also outside the hospital, but this episodes of confusion happens mostly in hospitalized patients, and especially in patients who are admitted to the intensive care unit. Now, if you're in the intensive care unit and if you're on a breathing machine and if you experience delirium, not only it increases your stay in the intensive care unit, it is also associated with other complications during your stay in the ICU that could include falls, pulling out your IV lines, and then pulling out your endotracheal tubes on the mechanical ventilation.
Oh.
And then when you are discharged, delirium is associated with a form of decreased brain function, a dementia-like syndrome, which we call ICU-acquired brain dysfunction, that can happen months after discharge from the ICU, and that can persist at least from the evidence that we have up to years after discharge from the intensive care unit. Now, in the context of COVID-19, it is so extremely important because patients with COVID-19, with their lungs principally affected, when they're in the intensive care unit, they are on the mechanical ventilation, and they're experiencing delirium at a higher rate compared to the delirium rates that we were observing years before the COVID-19 pandemic hit us. So if you put it in perspective, larger number of COVID-19 patients in the ICU, a higher percentage of them developing delirium. So the potential for complications, not only during their hospital stay, but also after discharge from the hospital is huge.
I'm trying to understand how common this symptom is. It sounds like, based on your description there, that it can happen while a patient is hospitalized, or it can develop after somebody has been discharged from the hospital and then become an issue. How often is this actually happening in your experience?
So in the intensive care unit, if you are on a breathing machine or a mechanical ventilator, and if your age is above 60 years old, 60 to 65 years old, the chances of you developing delirium are close to around 70 to 80% in the intensive care unit. Now, from our older data at IU School of Medicine, the rates of delirium in all comers to the intensive care unit falls within the 30 to 40% range. With COVID-19, irrespective of your age, if you're in an intensive care unit, the rates of COVID-19 associated delirium are 70 to 80% in the intensive care unit.
Well, Dr. Khan, we are glad to know that you are working to reduce this risk and treat it. Thank you for your time, and stay safe and have a great day.
So I'm smiling because I can't resist telling one of my favorite, somewhat off-color stories about working in the ER. And what reminds me of that story is this question about, well, what could it be? Could it be hypoxia that's causing this confusion? Could it be the cytokine storm? Could it be actual infection of the tissue? And one of the things that that as a physician, an experienced physician, I would lean towards saying, look, any of those can cause it, at least for the people that are having recurring long-term damage. It may not be hypoxia. It may be one of the other things, because yes, you can get long-term damage with hypoxia, but again, you're more likely to get it from those other two things. Now I got to tell the story. So there was one night I was in the ER. They brought in a lady from a local nursing home, and they said she had had a stroke. She was in her late 70s. She had basically stopped talking. I could not find any what we call localizing signs. That means a sign where, you know, part of the face is has changed. You can't move a certain body part or whatever. She had just stopped talking. And one of the things that I've always been as a doc is fastidious and obsessive compulsive. A lot of docs would not do a rectal exam, a complete exam, including a rectal exam, as part of an ER, emergency room admission, for a late 70s-year-old female with a potential stroke. But I did, and I found this impaction, and I ended up, again, pardon the imagery of this story, but I ended up digging and digging and digging, and ended up with a huge product of my activities. What was interesting, though, was the patient perked up and started talking. And we went ahead and admitted her that night, but I found out later on she was discharged the next day, doing completely fine. Now, what has that story got to do with COVID-19 brain injury? Well, again, what you have to remember and think about is hypoxia. There's a thing called the vasovagal response. It's when you have stimulation of organs, like in this case, the cecum or the terminal colon. That was obviously being stretched by this impaction that this patient had. That, in turn, was decreasing her heart rate. One thing I didn't tell you was that her heart rate was down in the 50s and 40s when she came in. After clearing that impaction, her heart rate popped right back up to 70. When it did, that's when she perked back up and started talking to me. So as you can see, just the lack of blood supply to the brain, that amount slowed this patient down enough to where she was no longer able to talk. So again, what you begin to see is decreases in oxygenation can result in these kind of neurological symptoms. The other thing that you see with that is quite often, especially if it's just some short-term, moderate to low-level hypoxia, decrease in oxygen, you're not going to get that much damage. People are going to perk right back up. So again, pardon me for if you didn't like that story, but it helps you think inside an ER doc's mind in terms of, what could actually be causing this? Is it hypoxia? Is it cytokine storm? Is it actual infection and impact on the tissue? The bottom line is it's going to be a while before we get that all figured out. So in terms of comment, Lori started off and saying, and just reminding folks that she's our nurse, she's working with us, and she'd love to hear about your health goals and concerns. You can reach Lori at 859-757-2324. That's 859-757-2324. Lori and Cindy and I have been doing some work with Janice and Michelle on getting our team geared back up post-COVID, post-shutdown, to start getting information back out to folks that are interested. Joe Reilly, Joe's made a couple of comments, and wouldn't he have had a better chance of surviving if he had had it during the stress test with the doctor and medical staff there? Oh, so this goes back. So let me go back and give you a little bit of backstory on that question. As you may remember, if you dialed in early, I was talking about the stress test that Tim Rustert had. I mean, he's the poster child, is the poster child for negative stress tests and then dying from a heart attack. And James Cantor heard that story and said, well, did his stress test and heart attack occur on the same day? Joe said no, and I provided some clarity. No, the stress test was in March, April time period. It was about the time of the, I looked up that date once, and I don't remember it right now. It was springtime. It was about the time of the Cherry Blossom Festival. His heart attack was a couple of months later in June. So James was saying, yes, thanks, and at least the stress test didn't cause a heart attack. That's very true, and it brings up a great point. Exercise with heart disease can be scary. I remember the first time that I documented my own plaque with a CINT. At that time, I was in my mid-50s, and I had the arterial age of a 73-year-old. That was not a happy day, obviously. And what was even more frustrating was that I expected to do a victory lap after my first CINT. I've been a preventive doc. I've done the right things in terms of prevention, or at least what was considered right at the time, from day one. I've kept my weight down, BMI in the low 20s, and for about 30 years was plant-based mostly. Never vegan. It was plant-based for health reasons. Then didn't really watch my carbs that much. It's been just been over the past 10 years or so that the science has really come out focusing on carbs and plaque. Anyway, I remember that first day, I would do a long run, about 2 or 3 hours, 10 to 15 miles, once a week on the weekends. And I remember after seeing that plaque for the first time and thinking, you know what, I'm getting ready to go out running. And I could. I mean, given where I'm running, it was a beautiful area here in Lexington, out in the horse country. But if I collapsed in one of the gullies next to the road, I could lay there for hours. Obviously, I wouldn't have hours anyway if I collapsed from a heart attack. I could die very easily. It was the thing that I had to push through and say, look, I do this for a living. From a science perspective, I know that exercise does not cause a heart attack. But, you know, there's knowing something, and then there's the emotional reaction. So again, James, thanks for bringing that up. Yes, to cut to the chase, I did go running, and I've been comfortable running since. But there's nothing that has shown. I mean, I think it was Jim Fix that had a heart attack while he was running. If you look at the statistics and the science behind people like Jim Fix and other folks that have had heart attacks when they were running, the bottom line is this. The heart attacks have occurred in running at the same proportion that the individual spent out exercising. In other words, running doesn't cause, exercise does not cause a heart attack. And as we know, exercise actually improves a lot of the overall baseline metabolism and decreases heart attack risk. We do know that. So where Joe was going, back to Joe's comment, maybe that helps you understand where Joe was going. Wouldn't he have had a better chance of surviving if he had had it during the stress test with the doctor and the medical staff there? Absolutely no question. If he'd had it there with the doc, but he had it in the bureau of NBC, CBS, whoever the group he was working for, and that led to a whole raft of discussion about having defibrillators there. He was actually defibrillated fairly quickly, and they defibrillated him 3 or 4 times on the way to Sibley Memorial Hospital, which was nearby. They just couldn't get him back. Willie 20, what are your thoughts on eating eggs 3 times a week? I used to think that that was an issue, 20, 30 years ago. We thought that, you know, if you take biopsies or autopsies and you look at what plaque is oxidized LDL. It's in the artery wall, arterial plaque we're talking about. In other words, it's made of cholesterol. So therefore, for a long time, we felt that things like eggs were a major risk factor for plaque and for heart attack and stroke death. That's not the case. Part of the logic that really began to put that in question was the issue of whether or not most of your cholesterol came from your diet. And the reality is we make cholesterol. Your liver makes tons of cholesterol, a lot more than you're ever going to eat. And so it wasn't just that, it was, again, continuing to watch this whole thing about cholesterol. At this point in time, you have to ask the question, you're about half the people that have a heart attack have a totally normal, quote, normal cholesterol value. So you actually get into discussions and debate. There are a lot of people taking the other side. I think his name is Nir Ali, is one of the more well-known YouTuber cardiologists, saying, no, you want to have a high LDL. So bottom line, I don't worry too much about LDL. And I clearly, gosh, 25 years ago, quit worrying about eating eggs. The final thing in the vegans platform for you are what you eat, and therefore don't eat eggs or don't eat animal products, is this thing of TMAO. And I've done several, trimethylamine oxide. I have done several videos on that. And the bottom line, short story on TMAO is it probably doesn't make a difference unless you already have some kidney function problems. Joe Isaac, what are your thoughts on high blood pressure, 160/100 during exercise, especially when blood pressure excuse me, returns to normal within minutes after exercise, you do expect almost always to get an increase in what we call the pulse pressure. The pulse pressure is the upper pressure, the systolic, minus the lower pressure, the diastolic. Now, usually, and what you get and what you want to have happen is a drop in the systolic. Actually, you usually get a slight increase in, did I say systolic? I meant diastolic. Usually what you want to get is a drop in the diastolic. You usually get a little bit of increase with the systolic and a significant decrease in diastolic. Some of us don't get so much of that. Joe, you don't get that either. I would, here's what I would recommend. People get really focused on one-time blood pressures. And one-time blood pressures are sort of like one-time glucose management. You really want to know what it's doing throughout the day. I'd recommend you get a blood pressure cuff. These things used to not be very accurate. They're pretty accurate now. They're really good. And take your blood pressure several times a day. If you have a question, take it. I know at our local gym, which nobody's going to anymore, the YMCA, because of COVID, they have one of these sitting right out there in the workout area. What I would suggest is you get one of those, start recording blood pressure multiple times per day during multiple activities, during exercise, post-exercise, things like that. Then you get a much better picture of what's going on. Jim Hyde, did you see any value, or do I see any value with KardioMobile? I think you might be talking iCardia. And Jim, I've got atrial fib myself. I suspected I had it from waking up a couple of times with fluttering in my chest and just knowing that I have risk. I also knew that I am homozygous for 4q25. Fourth chromosome, Q25 area. It's called the atrial fib gene. I've got an atrial fib gene variant from my mom and another one from my dad. So that means that the muscle cells of my myocardium, my heart muscle, tend genetically and metabolically to trip easily into more of a conduction cell rather than just the muscle cell alone. That's what 4q25 is all about. That's what the vast majority of atrial fib is about. Now, let me come back out of that bunny hole and tell you, I diagnosed my own atrial fib using iCardia. The original, I actually had one for years. The original iCardia was actually it was an iPhone cover, and it had two little electrodes on the back. You put that on the back, you put your thumbs on that, and you watch your tracing. It's not obviously a 12-lead EKG, but it's a rhythm strip, and the rhythm strip is exactly what you need. You get what the docs call an irregular rhythm with rates up 120, 150, things like that. So I hope that makes that clear. I am a big fan of it, and I am not the only one. Now, here's what I would say, though. The iCardia, it's less expensive. It's like $100, and there's now a bunch of competitors for the iCardia atrial fib screen on Amazon. I've got 24 videos on atrial fib, and probably 3 or 4 on iCardia specifically. Now, here's the other thing I would say, though. Since I did all that, Jim, past couple of years, the past couple of years, Apple came out with a cardiac, an atrial fib monitor. Now, here's the advantage to an Apple Watch monitor. With iCardia, you're waiting to see if you have symptoms. A whole lot of us can go into full atrial fib on a regular basis and never have any symptom at all. it doesn't matter if you're wearing an Apple Watch. And no, I have no stock, no payment, no financial arrangement with either iCardia or any of the other screens or Apple. And I don't own Apple stock. And, you know, that's Roscoe Tanner. Because of you, I, 67 years old, had a cardio risk CIMT showing the arterial age of 80. That's not good. That's the kind of shape I was in. Not quite as bad. Followed by a coronary artery calcium score of 351. Yes, I passed the stress test with flying colors, and I don't feel lucky. Thank you, Roscoe. It's when people share that kind of experience. It's one thing for a doc to get up and talk about what he does for a living all the time. It's a very different thing when somebody says, yep, I'm one, I did that, I had the same thing happen. Thank you, Roscoe. James Cantor, Joel asked Isaac, what does your blood return to, say, 15, 30 minutes after exercise? And Joe says around 120/80. And Joe, again, that's what I'm very interested in having you document, that is what happens. The only time you ever get that blood pressure problem is when you're exercising. If that's the case, I'm not so concerned about it. But that is back to normal after 30 minutes. Joe Reilly, Apple Watch, sinus rhythm now. Thank you, Joe, for sharing that. You know, I never got my own Apple Watch. I got that close to doing that once. But you may have noticed I can personally be fairly cheap in terms of my own experience. And the issue was, you know, I know I've got atrial fib. I also know that my atrial fib, like many, maybe most of us, is very, very sensitive to weight, to blood pressure, and my blood pressure is very sensitive to my weight. In other words, and it's also very sensitive to sleep and sleep apnea. So I'm like a whole lot of other people. If my weight gets significantly, if I get up to 165 pounds, my blood pressure is going to go up and my atrial fib is going to start kicking up. If I stay 160 or less, I hardly ever have a problem with it. So guess what? It's lifestyle, lifestyle, lifestyle. Erland FR, BBC podcast, Science in Action, 6/4, Autopsy, June 4th, I think. Autopsies show COVID-19 can affect the brain and other organs. Pathologist Marty Fowkes from the Icahn School of Medicine at Mount Sinai found the signs of stroke. Well, we do know that it causes not only major strokes, but multiple minor strokes as well. And we do know that that's in young people as well as the usual target, us older folks. So thank you, Erland. Roscoe Tanner, my wife, and Erland also. Does the apple cider vinegar drink clear up any blockage in veins? I hate to say this. It can happen. Number one, it's not the veins that we're worried about, Willie, 20. It's the arteries. Number two, here's how it can help. Short term, no, it doesn't have any roto-rooter type of activities, but apple cider vinegar tends to slow down the increase in blood sugar that you have. It slows down gastric motility and therefore slows down the increase in blood sugar that you're usually going to get after eating a meal. We call it postprandial hyperglycemia. So if you can continue to control the increase, the uptick in blood sugar and or the uptick in insulin in your blood, long term you can have a significant positive impact on the development of plaque and inflammation in your arteries. So that's where apple cider vinegar comes in. I keep thinking I'm going to do a series on apple cider vinegar, bone broth, and some of those things. But you know what? There's a heck of a lot more topics than there is hours in the day. Thank you so much for your interest.